We see a lot of people come into clinic with lower back pain. A lot of these people have had a long history of chronic pain, or others have more acute flare-ups. Regardless of this, the first port of call that we go through is a screening process to make sure that we've covered all red flags, which would point to more serious pathologies, which would require referring on for. Once we screen for these, we can then move on with the rest of the assessment. A common injury that we see in clinic is mild disc degeneration related pain. The discs in our spine undergo degenerative changes as we age. Some people experience symptoms because of this, but not everyone. The causes of this can vary. It can be that fluid has leaked out from the disc and is causing irritation on the nerve, or it can be that the discs aren't managing the stress of like normal day-to-day load as well, which means that you get poor loading through the spine, altered movement, and then the muscles contract around it, causing muscular spasms or tightening to try and protect the spine and manage load. Pain often reduces over time as the inflammatory proteins dissipate and the surrounding structures become less inflamed. The primary role of physio is to get the patient moving as quick as they can and comfortable ranges. So we're looking to re-educate the brain here, which is why it's important to not stress the no pain, no gain principle and go with we're looking to move in comfortable ranges that calm the area down and prevent highlighting the pain pathways that are being created. So we tend to start with light mobilization exercises, which get the patient moving in comfortable ranges, desensitize the tissues and don't create pain. We can pair this with some hands-on work that releases the muscles around it, which will then enable the patient to go away and perform their exercises with less pain. As this then becomes easier, we can increase the range of motion of which the patient is going through with these exercises and gradually increase load as the capacity of the tissues to manage the load increases. So we can take extension, for example, back extension, and we can mobilize this through a cobra stretch where the patient's lying on their front pushing up. We can start with small ranges of motion and progress on to bigger ones where they're pushing up even further. Once this is pain-free, we can then also load with some strength work. So say, for example, a W lift-off. We can keep the legs down first of all and just lift with the upper back. Normal principles of training overload can be applied, so we can increase the duration, the reps, the sets, and the tolerance of the tissue will gradually adapt and become stronger over time. Once the patient's happy with this movement in back extension, obviously we would have worked on all other ranges of movement as well. We can get more functional exercises in, such as RDLs, deadlifts, squats, back extensions, reverse hypers, all of those which will build that posterior chain, increase the strength around that patient's back and core, and prevent future injuries. So this is just a rough process in which a patient will go through to get them back to day-to-day activities or whatever sporting activities they go through, where they're now stronger than they were pre-injury.